Thank you. So we start with this session, invitational lecture 5, and it has to be delivered by none other than Dr. Gagandeep Singh, sir. I invite you to deliver the talk, and the topic is approach to visual hallucinations. Thank you, sir.
Thank you, Dr. Achal and Dr. Arvind. The onset, I want to thank President, the entire Scientific Organizing Committee for actually choosing this topic. I actually suggested this topic to him for a few reasons. One of them is that visual hallucinations has never ever been discussed, I think, in any of the recent INCONs. So I think it's worth it to be discussing. Thank you, Dr. Debashish, for keeping this topic. The second is I've been reading a lot about visual hallucinations, particularly in the last 2 years, and I read a very interesting layperson book. I'm going to allude to that book again and again in my presentation. And that's what got me interested. And third is the approach to visual hallucinations adopted by many of my younger colleagues. I mean, it's not uncommon to walk into the wards. On the floor, there is a patient, maybe Parkinson's disease or whatever, has hallucinations, and the resident says, "Well, this patient had hallucinations in the night. We gave him clozapine." Is that all that we really need to do about hallucinations, or is there something else that we can do? And I begin with a case. So this is a 62-year-old gentleman. He snakes very frequently. And this is the conversation that happened in the clinic. So I asked him, what color is the snake? It's khaki color. And how big? It is about 3 to 4 feet. And do the snakes move? Yes, they move very fast. And where are they? They could be anywhere. They had a rural home, so there are animals there. So it's often in the haystack or in the utensil basket. So then I ask him, what do you do with it? Well, I find it. I take a stick and try to find it in the haystack, right? One of the accompanying family members said that, well, we cannot see any snakes. And to which he replied, you fool, you must be really blind not to see a snake like this. So I asked him, the next question I asked him is, was he scared? So his answer was, no, I've seen many snakes and I've dealt with many snakes. Not an issue, not at all, right? So this was the conversation, ladies and gentlemen. I ask you, just add that most of these hallucinations occurred late in the evening as it became dark. What's your diagnosis? Very typical Parkinson's, right? So they can have hallucinations of people passing by in the periphery, or they can have what are known as presence hallucinations, where someone is sitting next to this. This is very typical, particularly hallucinations as it gets dark. In contrast, we have a young patient, 24 years old, and this is the transcript of the conversation that we had in clinic. What do you see? I see a demonic spirit. Can you describe it to me? Well, it comes very near me. Sometimes it touches me and then it speaks to me. What does it say? Well, you should come to the other word with me. It often touches me. Then I asked him, can you draw it? So he said, yes, and he actually drew it. In the next slide, I'll show you drawing. But I asked him a few more questions. What kind of clothes does it wear? It's a little difficult to say. I mean, I can't make that out very well. What color is the demon? Difficult to say. Then I asked him, does it frighten you? So he says, not really. I just take it for what it is. And this is diagram, the picture that he made of the demon. I have to say that drawings of visual hallucinations is extremely rare. I mean, I always keep in my clinic a set of drawing pencils, and many of my patients will draw a visual aura of epilepsy or a visual aura of migraine very nicely. But it's very uncommon for someone to draw a visual aura, or sorry, a visual hallucination associated with Parkinson's disease, dementia, delirium, or whatever. Perhaps it's the mental state. This is a diagram made by one of my patients. He sent it across to me. You can see that timing is very well represented. Minute to minute diagrams. It's a visual aura of migraine that increases. So it starts at 32 minutes past 1, slightly larger at 33 minutes past 1, 34 minutes past 1, and you can see it lasts for 58 minutes past 1. So approximately 20 to 25. How it evolves, becomes larger, and then fades. A beautiful diagram and a very good representation by one of my patients who just had visual. She had a history of migraines, but just had a typical aura without migraines. So, what are visual hallucinations? And visual hallucinations, we have visual illusions, and what are misperceptions? Often, hallucinations is basically seeing something when there is. So you can all see photograph. There is a bush, there are feet, sky, and the clouds. Someone sees figure of a huge man there. That is a hallucinator. That's an hallucination. And the hallucinator, one, believes that this is, often believes that this is very real, right? It's not as good as what we see in person. For instance, if I ask you to close your eyes, all of you have visited Taj Mahal, right? And if I ask you to close your eyes and imagine Taj Mahal, would you do that? I mean, you can conjure a figure, but it's not that bright, it's not that vivid, it's that it does not have the kind of detail. But a hallucination has a tremendous amount of detail. And based on the degree of detail, we can actually determine the cause of the hallucination. But often, the distinction between hallucinations, illusions, and misperceptions blurred. Many patients might have, many patients with hallucinations might also have illusions, right? And then hallucinations are pretty alarming, they're startling. People get scared of them, at least in the beginning, right? And the reasons why they get scared about them are two. One is if you see a big figure like this, you'll be scared. You see a big spider in a room, you'll be scared, right? But they're also scared that people might think that something is wrong with me, right? There's a mental problem and something is really wrong with me. So that's the two reasons people with hallucinations are often scared. They're worried, they're startled, they're amazed by the hallucination. Go on to another case. 6-year-old male, Parkinson's disease, female, sorry, diagnosed at 58 years of age. A whole lot of anti-drugs, levodopa, carbidopa, ropinol, but her MMSC is pretty good, 29, right? And she had these pervading hallucinations of children from the neighborhood playing in her backyard and her brother-in-law sleeping on her bed, right? Her husband actually came in with her. The husband actually told me and showed me a photograph in his mobile. See, I made this photograph of the backyard. I made this photograph of the bedroom. I went to her. I showed her that there is no one here. There are no children playing. But even in the photograph, she could make out the children were playing there, right? So that's the conviction of a person who's having hallucination. I've taken this extract from this book, which I mentioned, Visual Hallucinations by Oliver Sacks. I would request you to go over this particular extract by Oliver Sacks. I observed with Rosalie, that's the patient, been called to see her on an emergency basis, that her eyes were open and they moved from side to side, one object to the next object, as if she was scanning a natural scene. And this was what actually brought this whole thing to the nurse's attention. She said that she's been seeing these scenes for several days. That's a very typical history, several days. These scenes were more like a movie. The only thing was that the movie was a silent movie from 1920s. And this is what she said, just like a movie, some movies are good, some movies are interesting, and some movies are boring. The images were silent, so a silent movie, but they were really uncanny and real, right? Sometimes two-dimensional. And I've never experienced something like this. And she was obviously worried that she is developing some kind of mental disorder. So Oliver Sacks examines this patient and he writes, I found nothing suggestive of confusion or delusion. Absolutely normal, mentally very alert, neurologically normal. But when he examined her fundus, ocular fundus, he found that there was a considerable amount of retinal detachment. That was the cause of her illness. What's the diagnosis? Right? Charles Bonnet syndrome. Charles Bonnet was the person who first described visual hallucinations in his father. And he eventually also became blind and had a similar condition. So, few characteristics of visual hallucinations, Charles Bonnet syndrome, they can occur anywhere. They can last for days and days together, extremely vivid hallucinations, and they're silent. It's like a silent movie, right? So that's Charles Bonnet syndrome. And this is an old paper by James Lance, 1970s, and he describes a series of patients, 4 patients, who had a homonymous heminopsia or a visual field deficit, and they developed formed visual hallucinations in the heminopic. That is also something characteristic, something which I was really not aware till some time back. And then I started asking all my patients with heminopsias, and roughly I think about 20% of them admit to having formed visual hallucinations in their heminopsia. It's just that as physicians, we don't ask, and as patients, they don't tell. They're either scared that they might be labeled as a mental condition, or they think it is too insignificant to be told. So that's the reason why it does not figure out. And then you can have, there was this interesting patient, Dr. Najam, he would always feel that he's going up and would be an intense feeling of calm and joy. And she would rise up and above the word and she could actually see, right? There was a feeling, a levitation, a feeling of going up and a very intense, pleasurable feeling. This is exactly what he had, right? A DNT in the temporoparietal region. And you can actually feel rising. And this is different from a near-death experience in which, what the patient actually reports is going through a dark tunnel. There's light at the end of the tunnel, and very long tunnel. At the end of the tunnel, you actually see light, right? That's the near-death experience. It's something different, but it's somewhat semiologically similar. So you have autoscopic hallucinations where you see a double, out-of-body experience where you see, and most of these localize to the temporoparietal junction, that is superior parietal lobule and the superior parietal lobule. Then you can have something like this. Might be temporal, over a period of time. So the typical history is that you see an object, and then you turn your gaze somewhere else and you continue seeing the original object. You see someone walking in the street, and then you turn your eyes elsewhere and you continue to see the person repetitively walking in the street. Or you see multiple objects, multiple copies of the same object together. So this is an interesting picture from one of the papers where you can actually see lamp, and whenever the person shifts his gaze, he continues to see lamp. So palinopsia usually occurs with occipital lobe lesions. Lesions have to be small. If the lesions are too big, it is a huge infarct. You would not get palinopsia. In fact, you don't get hallucinations with large cerebrovascular infarcts involving the occipital. The infarcts have to be really small, right? And then there is, as I said, a lot of overlap between hallucinations and misperceptions, often in the dark. And if dark figures out here, someone might actually mistake them for a man, for human beings. And you have these flowers might actually mistake deep, right? So this is how, this is the overlap. And many patients with hallucinations, if you actually test, and this is one of the tests, bedside tests or neuropsychological tests for demonstration of visual hallucination. So, ladies and gentlemen, taken you through a few cases of hallucinations, many causes, many different causes, many different lesions, right? So it's not that there is a single unifying pathological mechanism. It's not that there is a single unifying lesion which can explain. You have hypnagogic hallucinations and all normally experience. Often patients have narcolepsy, usually occur whilst falling asleep. Peduncular hallucinations, I didn't speak of that, and sometimes the heralding feature of a midbrain or thalamic stroke can be peduncular hallucinations. And peduncular hallucinations can be really bright. I saw one picture of a hallucination where it was a little dim, blurred, but peduncular hallucinations can be extremely bright and very vivid. The amount of detail in the hallucination can be enormous, right? And this can be a feature of midbrain or thalamic stroke or other lesions, often associated with sleep abnormalities and eye movement abnormalities because of the particular location of the lesion. We read about Charles Bonnet syndrome. Delirium is another condition with lots of visual hallucinations, and they last for the entire period of the delirium. Parkinson's disease, the first case that I presented, typical hallucinations, passing hallucinations, presence hallucinations, more towards the night. So all you probably need to do is to switch on the light. Many of the hallucinations will disappear. Often they have hallucinations, have curtains, those huge curtains, and between the folds of the curtain, they might actually hallucinate. So just you spread apart, pull the curtains, hallucinations will disappear, right? So there are these conditions, and there are, in fact, some very good points in history and examination by which we can differentiate the causes of these hallucinations. A number of questions that we need to ask. It's not just that they come to the clinic, they complain of hallucinations, that's it, and we start them on clozapine. No, we need to find out when did they begin, how long do they last, which time of the day do they occur, as we said, as we discussed. Are they very colorful? Are they vivid? That's peduncular hallucinations. Do they see only on the corner of their eyes? That's passage hallucinations associated with Parkinson's disease, and so on and so forth. Many questions, right? Questions about whether the face is ugly. That's metamorphosia of the face, prosometamorphosia. Multiple copies, that's polyopia, alinopsia, and that tells us a lot about what is the lesion and where is the lesion, right? And last but not the least, and my last slide, um, just not enough say, okay, fine, you've got hallucinations and you start whatever, quetiapine or clozapine, or there's this new drug which has just come in our country. I'm sure in the US it was there for a very long time, Pimaverin. But we have just got it about a month ago. So people are going to use that. But I think what really required from the management standpoint is to discuss the nature of these hallucinations, the causes of these hallucinations, and to reassure the patient. That goes a long way. Reassure the family, reassure the patient. That goes a long way in managing. Many of the hallucinations stop bothering the patients and their families once you discuss with them the nature of these hallucinations and what these are all about. And then you need to look at medications. Sometimes just simply withdrawing medications can do the trick, right? There are, for instance, patient is on anticholinergics, they need to be withdrawn. MAO inhibitors, they need to be withdrawn. Dopaminergic stimulants, they need to be withdrawn. And some cases, very careful withdrawal of partial withdrawal of levodopa therapy. So this, and I just want to say that the use of antipsychotics should be a last resort. Quite often, the patient is comforted, the family is very much comforted as you discuss with them the nature of the hallucinations, explain them the basis of the hallucination. They're quite fine about it. Thank you so much. This was the book, Hallucinations. It's actually meant for laypersons, and I would encourage all of you to take this book and read. It's a wonderful book by Oliver Sacks.
Thank you. Thank you very much, Dr. Gagandeep, for the very lucid talk. If we allow the questions, or yeah, Dr. Amber, one question, and Dr. Devashish.
It's not working. Anyway, first of all, the thing about otoscopy, heutoscopy, and out of body experience, these are not considered to be visual hallucination. These are disorders of body image. And there are several things it can occur in migraine, it can occur in epilepsy, it can occur in people who actually recover from a cardiac arrest, and it can occur in people who have got highly religious sort of things. So that is the first point. The second point is about visual hallucination. There are hallucinations which are localizable, and there are hallucinations which involve the entire vision of both the eyes. Localizable means either they're temporal or they're hemianopic. These may be either migraine or some kind of epilepsy with a structural lesion, probably, with or without a structural lesion. But when it is involving the whole field of vision, we tend to call it psychosis. Psychosis may be organic, may be non-organic, means psychiatric disease. And it's wrong to always think about Parkinson's disease or DLBD for when you get a generalized, and this is, I'm telling from my own sad experience. My wife passed away in January of cerebral lymphomatosis. And the first symptom she had of the cerebral lymphoma was on 16th of August 2023. And she started seeing children all around and gave the thought that they must be fed before we have our lunch. That was the first symptom. And then she saw other people coming and trying to attack me. So, from visual hallucination with thoughts, they are suggestive of psychosis, which may be organic and not necessarily Parkinson's disease or anything, something diffuse in the brain. It can occur in Alzheimer's also. So these are and it may be non-organic when it's a part of schizophrenia or other psychotic which are there associated with auditory and vision. So that is the point I wanted to make.
Thank you, Dr. Amber. I think I agree with you that um, autoscopy and out-of-body experiences are not, technically speaking, they are not really hallucinations. But there is a lot of gray area, and the distinctions, as I said, between hallucinations, misperceptions, illusions are quite blurred places, and many patients might have a combination of these. And these are actually more visual experiences. They often occur in context of epilepsy, and as you said, people who have survived brain death.
Thank you, Dr. Gagandeep,